Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's live webinar, and that is on a very important topic, that is newborn survival blueprint. Key components clinician must prioritize. As we know that this topic is very much important, so we need someone who is expert. So without any further delay, I would like to invite our guest speaker for today's webinar, none other than Dr. Bharat J. Parmar sir. And let me share some of the achievement of sir. Sir has done MB in pediatrics and DHA FIAMS, and he is professor and HOD of pediatric department at Zydus Medical College and Hospital, Dahod, Gujarat, India. So without any further delay, I would like to invite sir and hand over this webinar to sir. Sir, the stage is yours. You can proceed from here. Over to you, sir.
Okay. Good evening to all. First of all, I am very thankful to uh, this IJCP group for giving opportunity to highlight my views, which are the important neonatal component for essential newborn care. For today's this CME, the theme is newborn safety every touch, every time, and every second. Important component of essential newborn care. For it is important for the intact survival of newborn. First component is antenatal care. Second component is safe delivery. Third neonatal component is neonatal resuscitation. Fourth, prevention of neonatal hypothermia. Fifth, prevention of neonatal hypoglycemia. Sixth, promotion of breastfeeding. Seventh, prevention of infection. And eighth, recognition of high-risk baby, referral and management. So these are the important components for essential newborn care or a first golden hour care. So which are the challenges and constraints for the essential newborn care or early newborn care or first golden hour care? The health and well-being of children are intimately linked with the health, nutrition, and status of their mother. Healthy and well-informed mother are likely to produce healthy and normal weight baby, whereas undernourished and high-risk mother are likely to produce high-risk and a low birth weight and extreme preterm baby. More than one-third of the women in our country are undernourished, with the body weight less than 40 kg, height is less than 145 centimeter, and hemoglobin less than 8 gram percentage. And they are prone to develop variety of infection, generalized genital colonization, and bacterial vaginosis with a high prevalence of pelvic inflammatory disease and unsatisfactory reproductive health. Around one half of the women in our country are illiterate and they lack personal and financial independence. The situation is further complicated by early marriage, teenage, and frequent pregnancy. The antenatal care of a questionable quality is available to 75% of the pregnant women, less than at 25% rural deliveries conducted by skilled birth attendant. The provision of essential newborn care is the most urgent key health problem in our country, and saving newborn in India is a national priority to achieve further reduction in infant mortality rate. There is a need for greater focus on a preventive rather than curative strategy because of large number of the neonatal deaths are potentially preventable disorders such as hypothermia, hypoglycemia, septicemia, and birth asphyxia. To reduce neonatal mortality, essential or a basic newborn care service should be available at all the healthcare level because they are highly cost effective. The component of essential newborn care service include good quality of antenatal care, at least 3 antenatal visits, safe delivery, and optimal care at birth, promotion of exclusive breastfeeding, and prevention and early treatment of hypothermia and bacterial infection. The level of newborn care. The based on a birth weight and the gestational age, the three-tier system of neonatal care is provided in developing countries. The level 1 care. Level 1 care, more than 80% of the newborn require minimal care can be prevent their for their mother under the supervision of basic healthcare professional. The neonatal weighing more than 1800 gram or gestational maturity more than 34 weeks or more, it belongs to this level 1 care. The care can be provided at home, subcenter, or primary health care centers. The basic care at birth, provision of the womb, maintenance of asepsis during delivery, and promotion of breastfeeding from the mainstay of a level 1 care. The traditional birth attendant and community healthcare workers must be trained in the art of essential perinatal care. The level 2 care. The level 2 care is important for infant weighing between 1200 gram to 1800 gram or having gestational maturity between 30 to 33 weeks. It needs specialized neonatal care supervised by trained nurse and pediatrician. The teaching institute, district hospital, and the nursing home should be equipped to provide intermediate neonatal care. The equipment of resuscitation, the maintenance of thermoneutral environment, and intravenous infusion and gavach feeding, phototherapy, exchange transfusion should be provided by level 2 care. The, the immediate neonatal care is needed for approximately 10 to 15% of the newborn population and should be available at all hospitals catering 1,000 to 1,500 deliveries per year. Level 3 care. The intensive neonatal care is required for baby weighing between 1200 gram and those born before 30 weeks of gestation. The PEX Institute or the Regional Perinatal Center equipped with these centralized oxygen and suction facilities, servo control incubators, and the vital sign and transcutaneous monitor, ventilators, and infusion pump, and so on, are busy suited to provide intensive neonatal care. Approximately 3 to 5% of the newborn population qualify for intensive care. The first important component pertaining to essential newborn care or a first golden hour care is the antenatal care. Antenatal care is the important element to ensure maternal, fetal, and consequently neonatal well-being. The objective of antenatal care aim to protect, promote, and maintain the maternal the well-being and to identify high-risk mother and plan appropriately and teach her element of neonatal care, breastfeeding, and the sensitize her for family planning. The schedule of care. Ideally, each mother should attend antenatal care clinic once, mother in first 7 months, and twice a month in next 2 months, and the weekly thereafter. However, minimum 4 visits are essential during third, sixth, eighth, and ninth month. The component of antenatal care, it includes during first visit registration, complete health history and obstetric history, investigation, hemoglobin, urine ABO, RH type, VDRL, HIV, and USG abdomen. During the subsequent visits, the physical re-evaluation for weight, BP, and edema to exclude preeclampsia or toxemia pregnancy and pregnancy-induced hypertension, and obstetrical evaluation for well-being, fetal well-being. The breast examination and counseling and investigation hemoglobin, urine, USG of abnormal case. The nutritional supports, the dietary counseling and supplementation of additional 400 calories. Iron and folic acid supplementation, 60 milligram of iron, 500 milligram of folic acid, 4 months onwards. The tetanus immunization, the two doses 1 month apart, the last dose at 1 month before delivery. In previously immunized case, one dose is necessary at the last month of delivery. Identification of high-risk mother during antenatal period and arrange more skilled care for them while continuing to provide appropriate care for other low-risk mother. Fetal monitoring include clinical, radiological, physiological, and of the fetus in utero for well-being of the fetus. The assessment of gestational duration by last menstrual period, uterine fundal height, fetal events, appearance of heart sounds at 16 to 20 weeks, and quickening at 18 to 20 weeks of gestation. The USC assessment, crown heel length up to 12 weeks, and biparietal diameter is the 36 weeks, 34 weeks, and femoral length beyond this age. The assessment of fetal growth maternal weight gain, it is 9 to 10 kg in pregnancy, and abdominal girth 1 centimeter per week from 20 week onwards, serial increase in uterine fundal height. The USC assessment, multiple pregnancy, congenital anomalies, abnormal placenta, morphology, polyhydramnios and oligohydramnios, fetal head, thorax, and head abdomen ratio. The assessment of physiological maturity for a lung surfactant maturity LS ratio more than 2, amniotic fluid density more than 0.15, renal maturity, there is alpha, this alpha fetoprotein creatinine more than 2 milligram per DL, and skin maturity, the AF cytology more than 20% of orange staining cell. The detection of congenital anomaly, USG karyotyping, amniotic fluid biochemistry, specific enzyme assay in a suspected inborn error of maternal and amniotic fluid alpha fetoprotein. Assessment of fetal distress, there is a fetal heart monitoring, fetal activity record, and fetal skull blood sampling for blood gas analysis. Second component for essential newborn care is a safe delivery. The basic delivery room care begins even before the birth, an important component for essential delivery room care as follows. The pre-delivery review of antenatal health record, although the need for newborn resuscitation may arise unexpectedly, it is possible to identify many high-risk pregnancy by review of antenatal record and refer them to adequately equipped center. The pre-delivery preparation in labor room to receive the baby and resuscitate if needed. This include all normal delivery should be attended by trained medical and health attendant. The labor room temperature should be 28 to 30 degree to avoid sudden heat loss at birth. Warmer should be switched on at least 15 minutes before the expected delivery. The pre-warm baby receptacle lined with clean linen should be available to receive the baby after delivery, along with enough supply of extra linen. Availability of essential resuscitation equipment and drug should be ready in a working condition. The universal safety precaution for infection control are necessary to protect not only the baby beat, but also the heart's health staff. The 5C 5 clean to ensure minimal asepsis during delivery include clean hand with quality hand washing and use gloves and clean surface to receive baby and clean blade to cut the cord and clean clamp or tie the cord and clean dry cord with a no local application. So aseptic precaution delivery by 5 clean. Intrapartum intervention. The oropharyngeal section should soon after delivery of fail, which was earlier advised in a newborn with the meconium stained amniotic fluid, is no longer recommended. Timely clamping cord. Normally, the cord should be cut after at least 30 seconds by the sterile blade, leaving at least 2 to 3 centimeters of umbilical stump and tied properly to avoid slip ligature and bleeding and early umbilical cord clamping. Less than 30 seconds is not recommended unless neonate is asphyxiated or needs to be moved immediately for resuscitation. Early clamping or cord is recommended baby with RH-ISO immunization and firstborn weaned baby. The delayed clot clamping is recommended in IUGR baby and anemic baby. Third component is neonatal resuscitation. Although most of the newborn do not require any resuscitation beyond the maintenance of temperature, suctioning of airway, and mild stimulation and the perinatal events, the birth asphyxia may preclude smooth neonatal cardiopulmonary transition unless assisted. The primary goal of neonatal resuscitation is to establish adequate respiration and cardiac output in asphyxiated newborn at birth to prevent early neonatal morbidity and mortality, as well as late sequelae of hypoischemic damage. Basic principle of neonatal resuscitation include measure to restore the maintain four cardinal body function, temperature, airway, breathing, and circulation, often referred to TABC of resuscitation. Resuscitation alert, preterm and the postterm delivery, malpresentation, the breech transfer presentation, obstructed and prolonged labor, signs of fetal distress, meconium stain liquor amnia, altered fetal heart sound and movement, and abnormal taste of fetal well-being, premature rupture of membrane, cord prolapse, cord around the neck, interventional delivery, LSCS, and forceps delivery, and the low Apgar score less than 4, these are the indication of neonatal resuscitation. High risk pregnancy, they require this neonatal resuscitation. The maternal, there's a preconceptional, the age is less than 60 or more than 40, the primary or a grand multipara, maternal malnutrition when the hemoglobin less than 8 gram percentage, the maternal weight less than 40 kg, and maternal height 145 centimeters less than this. It is a maternal malnutrition is a high risk pregnancy. And the maternal anemia, chronic medical disease, diabetes, hypertension, cardiopulmonary, and the renal disease in the pregnant mother, Rh negative blood group, and bad obstetric history. These are the high risk pregnancy. It requires neonatal resuscitation. Obstetric antenatal care, there is multiple pregnancy, acute medical and surgical illness, there is abdominal trauma, torch infection, or a sexually transmitted disease, pregnancy-induced hypertension and preeclampsia or eclampsia of the pregnancy, vaginal bleeding, there's a placenta previa, antepartum hemorrhage, polyhydramnios or oligohydramnios, and the fetal abnormality, there's the abnormal maturity, and the congenital malformation. So these are the indication for high-risk pregnancy, it requires neonatal resuscitation. The TABC of neonatal resuscitation. There's a temperature control, warm under radiant warmer, drying of baby, removal of wet linen, airway patency by proper positioning, oropharyngeal suction, breathing by tactile stimulation, positive pressure breathing, and endotracheal intubation. So this TABC for neonatal resuscitation. In high-risk pregnancy, circulation by chest compression and medication. So TABC is important for neonatal resuscitation in a high-risk pregnancy. The cord blood sample must be collected by blood grouping and cross-matching and screening, USG screening, or also screening for intrauterine infection. There's a torch infection. Receiving the newborn, the prevention of sudden hypothermia at birth is the most important component of immediate newborn care. As soon as the cord is cut, the baby should receive in a pre-warm tray, transport under warmer, and wipe gently to clean and dry the baby immediately after the delivery to prevent hypothermia. No extra effort should be made to remove vernix that protect against hypothermia. The wet linen after wiping the baby should be discarded and changed. Warm chain is important to prevent hypothermia in newborn. The warm chain is a set of interlinked procedure carried out at birth which will minimize likelihood of hypothermia in all newborn. And it must keep the warm at place, there's a home and hospital, during the transport from home to hospital and within the hospital. The common situation where the cold stress can occur in newborn at birth, after giving bath, during changing the nappy and cloth, malfunction, heat source and removing baby from heat source, and while transporting the sick baby from hospital to home and for referral. The step to prevent heat loss in a labor room. Keep the delivery room at 25 degrees centigrade temperature. The newborn care corner temperature should be maintained at 30 degrees centigrade. Drying immediately, dry with one towel, remove the wet towel and cover another pre-warm towel to prevent hypothermia in newborn and warm transportation. Step to prevent heat loss in postnatal ward, promote the breastfeeding, appropriate clothing, cover the head and extremity, keep mother and baby together. There's a kangaroo mother care, skin to skin contact, and keep the room warm and postpone the bathing till next day. How to keep baby warm? Use the dry warm towel to hold the baby at birth. Remove the wet towel after covering the baby with the sterile another towel. Adequate and appropriate clothing, skin to skin contact next to the mother, rooming in, radiant warmer in nursery, and keep the room temperature of the baby care area more than 25 degrees centigrade, and it prevents hypothermia in newborn. How to keep room warm? Avoid using air conditioner during summer. Don't use ceiling fan, especially at high speed, and keep the window and door closed in a winter. Warm the room by heater. Kangaroo mother care or the kangaroo mother care is a specialized way of carrying the low birth weight baby, and it improves their health and well-being by promoting effective the temperature control, breastfeeding, infection, and the bonding. The two components of kangaroo mother care, skin to skin contact, their early continuous and the prolonged skin to skin between mother and her baby is a basic component of kangaroo mother care. The infant is placed on her mother chest between the breast and exclusive breastfeeding. The baby on kangaroo mother care is breastfed exclusively. Skin to skin contact promote lactation and thus it facilitates extensive breastfeeding. And the prerequisite for kangaroo mother care support the mother in hospital and home and post-discharge follow. The benefits of kangaroo mother care, there is effective thermal control, increased breastfeeding rate, early discharge of newborn, less morbidity at apnea and infection per, to preterm baby, and less stress to the newborn and mother, and better infant bonding. So these are the benefits of kangaroo mother care. The prevention of hypoglycemia. Hypoglycemia is the most commonest metabolic problem in newborn, defined blood glucose value less than 35 milligram per dl during first 3 hours, less than 40 milligram between the 6 hours, and 45 milligram per dl beyond first day with clinical manifestation, and there is a irregularities of the gestations. The etiology of the hypoglycemia, the normal fetal glucose level are two-thirds of the maternal value, which drop further during first 2 hours before the rising again to normalize 3 to 4 hours of the age. The poor fetal reserve in the preterm baby and the low birth weight baby and the delayed feeding, that's the most common cause of neonatal hypoglycemia. The clinical manifestation of hypoglycemia not necessarily correlate with the blood glucose level, and most of the cases between second and the third day after the birth. The symptomatology of this neonatal hypoglycemia, abnormal movement, there is a jitteriness, tremors and the seizures, abnormal behavior, apathy, limpness, refusal of feed, and the coma, and autonomic disturbance, there is a recurrent apnea, tachycardia, and the sudden pallor and the sweating. So these are the symptomatologies and the signs of neonatal hypoglycemia. The diagnosis raised the low glucose level, preferably by the standard method, gastrotics, though adequate for screening are not reliable at a very low glucose level. The prevention of hypoglycemia include early breastfeeding, routine glucose monitoring in high-risk newborn at third day, third hour, 24 hours, 48 hours, and 72 hours after the birth of the baby, and the prevention and the treatment of precipitating factor like sepsis and hypothermia. Risk factor for neonatal hypoglycemia. So, which are the risk factor in newborn? The preterm low birth weight baby or IUGR baby, last for date or the postterm baby, infant of diabetic mother, delayed and inadequate feeding, RH incompatibility and exchange transfusion, and critical illness, polycythemia, sepsis and hypothermia, and inborn error of metabolism. The management of neonatal hypoglycemia. The management depends on severity of hypoglycemia. IV correction is recommended only in symptomatic baby, and asymptomatic hypoglycemia does not need IV correction and treated adequately with the feeding and additional sugar fortified feed if necessary. However, the case with blood glucose less than 20 milligram per dl must be reassessed after 30 minutes of feeding, and the need maintenance IV dextrose therapy as below it persists more than 35 milligram per dl. Manifest hypoglycemia is treated with bolus 2 ml per kg, 10% dextrose, and subsequently all symptomatic baby should receive maintenance IV dextrose 10% 2 to 20 milligram per kg per minute till glucose level approach 60 milligram per dl, followed by gradual tapering. The resistant hypoglycemia, refractory hypoglycemia to glucose bolus treated in order of preference. First, give IV hydrocortisone 5 milligram per kg, then glucagon IV or IM 300 milligram per kg, and rarely, and this diazoxide 25 milligram per kg per day, 8 hourly IV or orally. Glucagon is more useful in high insulin hypoglycemia, infant of diabetic mother, and hemolytic disease of newborn. Glucagon. Glucagon is more useful in high insulin hypoglycemia, an infant of diabetic mother, and hemolytic disease of newborn. The outcome of this refractory hypoglycemia, untreated symptomatic hypoglycemia, may be fatal, though timely intervention ensure dramatic recovery. The persistent hypoglycemia in newborn may have neurodevelopmental problem in 30 to 70% of the cases. The promotion of breastfeeding. It is essential to help the mother of a healthy newborn baby to establish breastfeeding as soon as possible after delivery. Exclusive breastfeeding should be given for first 6 months of life, and complementary food should be started after 6 months of life. The advantage of breastfeeding, the benefits to the baby, complete food, species specific, easily digested, well absorbed, protect against infection, diarrhea, pneumonia, promote emotional bonding, and better brain growth. The benefit to the mother, it helps in involution of uterus, delay pregnancy, there is a lactational amenorrhea, and the lower risk of the breast and ovarian cancer and decrease mother workload. The benefit to the family and society, it save money and contribute to the child's survival. The breastfeeding should be continued during diarrhea as well as the minor illness. Help the baby to get optimal nutrition and recover from illness faster. The good attachment and good position will ensure effective sucking, and there is in pre there is a retracted nipples and the breast engorgement. Infant take several slow deep suck followed by swallowing, then pause means effective sucking. There's a suck is slow and deep, and there's a pause is a effective sucking. The breastfeeding is considered adequate if the baby infant passes urine 6 to 8 times in 24 hours, sleep for 2 to 3 hours after feed, and gain weight adequately. So these are the indication for adequate enough breast milk in the newborn. The key message is to promote exclusive breastfeeding. Put the baby to feed at breast as soon as possible after birth, preferably in the delivery room. And this is important for the mother, baby, and the milk production. On the first day, the breast milk is thick and yellowish. It is known as colostrum, and this milk provides nutrition and it prevents infection. Do not discard colostrum. Keep the baby close to the mother. It is safe for baby to sleep with mother. Mother may lie down or sit on the bed and chair and floor to breastfeed her baby. The breastfeed during the day and night at 8 to 10 times adequate frequency, and whenever the baby cries with hunger. So, so also give night feeding to prevent hypoglycemia in newborn. The more the baby suck at breast, more milk the breast will produce and healthier the baby becomes. The give baby only breast milk for first 6 months, and do not give gouty, water, dried water, honey, animal or powder milk for these first 6 months, and never use bottles and pacifier for giving this milk, cow milk. The prevention of infection, there's a clean chain. The baby are securely placed in their mother womb. When they are born, they are protected from adverse environment of surrounding and cleanliness at the delivery. There's a risk of infection for the mother and baby, especially neonatal sepsis and the tetanus. So it requires the aseptic precaution during the delivery. It requires mother, family, and health professional to avoid harmful tradition practice and prepare necessary material. So hand washing is a single most important step to be emphasized to both for the family members and the healthcare workers. So important component of clean chain is a hand wash. The component of clean chain, there's a clean delivery, WHO 6 clean, clean attendant hand, there's a wash with soap, clean delivery surface, clean wing to tie cord, clean cloth to wrap the baby, and clean cloth to wrap the mother. After delivery, all caregivers should wash hands before handling the baby. For prevention of neonatal also, there is a minimum handling of the baby. Feed only breast milk. Keep the cord clean and dry. Do not apply anything on cord and use the clean cloth as a diaper and napkin and wash your hand after changing diaper, napkin, and keep the baby clothed and wrapped with head cover for prevention of hypothermia. The recognition of high risk baby referral and the management. The high risk newborn define the newborn with abnormal maternal, antenatal, peripartum, and neonatal indicators suggestive of higher than the normal risks in the morbid neonatal morbidity and mortality, who should be under close observation by experienced pediatrician and trained nurse. The indicators of this high risk newborn identified at birth: there's a high risk pregnancy, high risk delivery, postnatal characteristic, there is abnormal gestation, birth weight, congenital malformation, and early identification of high-risk pregnancy during antenatal visits, referral to suitable neonatal care center, any possible intrauterine intervention. The comprehensive review of case record before delivery for resuscitation alert and adequate resuscitation facility and expertise at the time of delivery. Assessment of delivered newborn for at any high risk profile and warming the baby during transport. There is appropriate for neonatal care centers. There is a tertiary care centers. So during transport, preventions of hypothermia. Thank you.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by one?
Okay, yes.
I can see the first question is from Dr. Subramaniam. He's asking, what is the single most critical intervention beyond routine drying and wrapping that should be initiated immediately after birth to prevent mild hypothermia?
So immediately after the birth of the baby, the important component there is a prevention of hypothermia. So by drying and covering of the baby and to prevent hypothermia in newborn. And second important component after the delivery, there is the early feeding. In the normal delivery, start the feeding first half hour after the delivery and 4 hour after in the cesarean section. So two important components for first golden hour care, the prevention of hypothermia and prevention of hypoglycemia in the newborn.
Thank you so much, sir, for sharing your point to that question, sir. Moving forward, we have another question. It is from Dr. Priyadarshani, and like she is asking, sir, this question is related to resuscitation, sir. Sir, a full-term infant failed to initiate adequate breathing after 30 seconds of stimulation, positive pressure ventilation is started with room air after 90 seconds of effective PPP, sir, what should be the initiative will be taken, sir? Can you please share some point on that?
So is a full-term baby. In the full-term baby, after tactile stimulation, there is a no improvement. Then give these chest compressions and then give there is a ventilator support to the newborn.
Thank you so much, sir, for answering this question, sir. We will be taking one last question, sir. If you adopt for observation, what are the two most critical clinical laboratory parameters you would strictly monitor, and what at what specific point you will consider drawing a full blood count and C-reactive protein, sir?
So important component these the preventions of neonatal infection. So primary prevent the neonatal infection during there's a safe delivery is important by the five clean. And second, I have been told there is a clean chain for the prevention of neonatal infection. So to see this, what is the blood count? There is a complete blood count, and also see the what is the CRP of this baby, and to rule out this neonatal infection.
Thank you so much, sir, for answering this question, sir. And I hope, sir, like participant has received his answer. I can't see any further questions, sir. One feedback from Dr. Priyanshi. She has written, "Thank you, sir, for this amazing topic and presenting it for our understanding." I hope, sir, you have done justice this topic, sir. As there is no more questions, sir, with all your permission, shall we conclude this webinar for today?
Okay,
Thank you, sir, and we would like to see you in future also with different topics, sir. It was great honor to host you, sir, and we would like to see you in future also. Take care, sir. Have a great day.
okay, okay. Thank you. Good day.
Welcome, sir.
Bye.